This is the first of a 4-module series on chest X-ray interpretation as it relates to anesthesia providers. This module will cover fundamentals of interpretation, indications, and appropriateness. The objectives and aims of these modules are to provide basic information regarding perioperative chest X-rays, encourage provider proficiency in chest X-ray interpretation, facilitate learning through a virtual presentation medium. These modules are not comprehensive in-depth coverage of all indications or pathologies the examiner may encounter with perioperative chest X-rays, nor are they intended to guide diagnoses of pathologies using chest X-rays. This is just an overview of how X-rays work. X-rays pass through the body and translate anatomic structures into images based on the structure's densities. Bone and metal are dense and resist X-ray passage. They appear white or radiopaque. Water and soft tissue appear gray to white and signify fluid-filled organs and soft tissue or fluid-filled lesions. Fat is more lucent than bone and soft tissue but more opaque than gas, and it appears gray. Gas is the least dense and appears black or radiolucent on a radiograph. When initially reviewing an X-ray, the acronym RIPE may help you to remember the basic features of the image that require attention. The acronym represents rotation, inspiration, position, and exposure. Rotation refers to the patient's alignment in the chest X-ray. Using the patient's clavicles as landmarks, draw a horizontal line. Patient misalignment may alter the size and shape of anatomical structures. Note the patient's tracheas in the chest X-rays. Next, consider the role the respiratory cycle plays in lung visualization. Optimal inspiration places the diaphragm at the level of the 8th to 10th posterior rib. We will discuss approaches to counting the ribs in a later slide, but note the difference between the diaphragms in the images of the patient during inspiration and expiration. While inspiration is typically preferred in conditions like a suspected pneumothorax, patient expiration may be helpful. Position refers to where the X-ray machine is in relation to the patient's physical stance. The 3 common chest X-ray views include posterior-anterior, PA, anterior-posterior, AP, and lateral views. The PA view, the X-ray beams pass through the patient from posterior to anterior. This approach requires the patient to stand during the procedure. Conversely, in the AP orientation, X-ray beams pass through the patient anteriorly, typically while the patient is in the supine position. Practitioners may request the AP view in portable chest X-rays for patients who are unable to stand. While portability and accessibility are advantages of the AP orientation, clinicians should be aware that this view will magnify anterior thoracic structures, including the cardiac silhouette. In the lateral view, the X-ray beams project from right to left. When examining the lateral view, the right chest is typically closer to the X-ray machine. The lateral orientation allows examiners to view anomalies behind the heart. X-ray technicians achieve the most thorough examinations with both AP and lateral imaging taken during maximal inspiration. Note image exposure and quality by assessing the opacity and brightness of anatomic structures. The image on the right is underexposed. Anatomy in underexposed images appear bright white or radiopaque. Note the lack of identifiable thoracic vertebrae in the chest X-ray. Conversely, the image on the left is overexposed. Overexposed chest X-rays appear dark or radiolucent where the rib structures should be. In these chest X-rays, the vertebrae are usually more defined than in images with optimal exposure. Again, using a systematic approach may help when examining chest X-rays. The mnemonic A, B, C, D, E, F represents anatomic structures of the chest X-ray. On this slide, we address the A and B of the mnemonic airway and bones. When assessing airway, note the position of the trachea. It should be midline, however, a slight rightward shift around the aortic arch is considered a normal finding. Generally, a deviated trachea indicates a pathology that requires follow-up. However, it's important to consider patient rotation and position when the pathology is an unexpected finding. Inferior to the trachea, identify the carina. Normally, the carina lies between the T4 and T6 vertebrae. Branching off of the carina are the right and left main stem bronchi. Next, assess the bony structures of the thorax noting any deformities or fractures. Features of optimal patient rotation include vertebrae that are aligned between the clavicles and scapula that are out of the way of the lung fields. When assessing ribs, the anterior ribs angle inferiorly from the lateral aspect of the image, while the posterior ribs arch superiorly from the lateral aspect of the image. With maximal inspiration on a PA view, the examiner notes 9 to 10 posterior ribs. Next, identify the intercostal spaces, which should be symmetrical. Larger intercostal spaces indicate an air trapping pathology consistent with conditions such as COPD and bronchial obstruction. Circulatory assessment includes examining cardiac features and vasculature. The cardiac silhouette should be no more than 50% the width of the thorax. The AP approach to chest x-rays may result in falsely enlarged cardiac imaging. However, cardiomegaly and pericardial effusion are possible etiologies of a large cardiac silhouette. So again, it's important to note x-ray rotation or approach. In a healthy patient, the mediastinum appears clear with some vasculature noted around the heart. Obvious vascular structures on a healthy patient include the superior vena cava, the aortic notch, the main pulmonary artery, and the right and left pulmonary artery and hyla. The hyla are networks of pulmonary vasculature on the medial aspects of the lungs. Visible lymph nodes around the cardiac structures warrant further investigation. In the absence of pathology, the diaphragm curves superiorly in the center, with the right side being higher than the left due to the liver. In pathologies such as pneumothorax or COPD, the examiner visualizes more than 10 ribs, and in conditions such as abdominal distension and atelectasis, fewer than 9 ribs may be visible on imaging due to diaphragmatic displacement. Examining lung edges and fields includes noting air and fluid collection. Identify the costophrenic angles located bilaterally distal to the diaphragm. Poorly defined non-acute costophrenic angles appear in patients with a hemithorax, pneumothorax, or pleural effusion. Consider patient rotation and positioning when noting the presence of fluid or air in the lungs. Keep in mind that fluid follows gravity while air moves in the opposite manner. The lungs are located from about C7 to T10 and include the right upper lobe, the right middle lobe, and the right lower lobe, as well as the left upper lobe and the left lower lobe. Lobes are rarely clearly defined in the absence of pathology. Awareness of perioperative chest x-ray appropriateness and indications reduces costs to patients, curbs misuse of facility resources, and fosters optimal patient care. The chart on this slide outlines inclusionary recommendations by the American Board of Internal Medicine, the American College of Radiology, and the American Society of Anesthesiology. The Centers for Medicare and Medicaid outline exclusionary criteria for preoperative chest x-rays. Keep in mind that the inclusionary criteria exist to provide guidance, and that provider discretion based on the patient's condition is best practice. In general, patients of advanced age and those with known or suspected cardiac or pulmonary history warrant preoperative chest x-rays. While preoperative chest x-ray appropriateness is important, it's equally important that anesthesia providers consider intraoperative and postoperative chest x-ray indications. Half of the anesthesia closed claims from 2010 to 2014 that involved patient death in the post-anesthesia care unit were the result of respiratory complications. Among these complications were a missed esophageal intubation, pulmonary edema due to fluid volume overload, and pneumothoraces. One case of pneumothorax involved a subclavian central venous catheter malposition in which anesthesia providers cited reliance on the radiology department to report an error. These complications are examples of intraoperative and postoperative events that healthcare providers may have identified prior to patient demise had the healthcare team utilized chest x-rays properly. Therefore, confirming proper placement of endotracheal tubes, central venous catheters, and pulmonary artery catheters that will remain in place outside of the surgery suite may prevent complications, expedite treatment of unknown complications, and serve as documentation of positioning in the postoperative period. Providers may consider chest x-rays in the operating suite or during the postoperative period when unexplained cardiac or respiratory symptoms occur or to further assess a suspected complication. This concludes the first module on perioperative chest x-rays. If you would like further information regarding topics covered in this module, we have provided a list of resources used.